All right, good afternoon. Thanks everybody for being at Medical Grand Rounds. A couple things before we announce our speakers. One, you see the CME MOC request. Make sure we grab that. There's another request there asking for nominations for Grand Round speakers for next academic year. So the time that we start asking for speakers and inviting for speakers really comes after January. And so we really want to hear from you in terms of who do you want here? We've had some incredible speakers already this year. Commissioner Califf was just here from the FDA. We want those types of nominations so then we can have really a runway to be able to bring them out and make those plans. So when you see that circle up, make sure you get the QR code and give us some nominations. Other announcements, no grand rounds next week for the Thanksgiving holiday. And then the following week, the first week of December, is when Vineet Chopra will be giving his State of the Department address, which is always a time to reflect and then look forward to kind of what the year will bring and what the priorities for the Department of Medicine will be. So that should be a really good talk. Anything else, MFA, that I missed? No, okay. Well, today we have a special talk. We have one of our own here, Dr. Hilary Lum, who's going to be speaking to us about guiding an improved dementia experience at UCHealth. And so really interesting to see how she envisions dementia care at UCHealth. Dr. Lum is an associate division head and associate professor in the Department of Medicine in the Division of Geriatrics here at the University of Colorado. She's also co-director of the CCTSI Clinical Faculty Scholars Program and co-director of the Multidisciplinary Palliative Care and Aging T32. Dr. Lum completed her MD PhD. PhD was in cell and molecular biology at the University of Wisconsin. Go Badgers, appreciate that. And then completed her internship and residency at the University of Pittsburgh Medical Center, and then came here for her geriatric and palliative care fellowship, which she completed in 2013. She's a nationally recognized leader in advanced care planning and dementia models of care. She's dedicated to implementing innovative care models to improve care for older adults with serious illness and their family care partners. I could go on and on. She told me not to, so respect that. She's incredibly well-funded with consistent NIH funding for over a decade. It's a delight for us to have Dr. Lum here. Please, thank you.
It is wonderful to be here. Thank you all for joining. Thank you to those at the VA, at Denver Health, and online. Hello to my mom who is logging in. So it is really exciting and a privilege to present in particular here on this topic because I get to highlight the work that we're doing at UCHealth related to guiding an improved dementia experience. So in terms of financial conflicts to disclose, I don't have any in particular. I do receive funding related to dementia care and care partner support from multiple sources for which we're grateful, and it's an opportunity to advance the work that we do. I also want to begin with the thank yous. This work that we're going to move through today is partnership and collaboration for many of us, including CU Medicine and Office of Value-Based Programs, the Seniors Clinic team at UCHealth, neurology and neuropalliative clinics, the palliative care team, especially inpatient, social work and care management, agile pathway teams, and UCHealth Epic team. So truly a team effort. So you perhaps know if you are attending a talk led by a geriatrician, if we begin with an anecdote or a story related to a grandmother or a grandparent. So this is my grandmother when she was 84. Her goals of care were to live, to see and be present with her great-grandchildren. That involved end-stage renal disease, peritoneal dialysis, and at one point I counted during my palliative medicine fellowship, 18 different transitions of care. That was tricky for me to process as a family member and as a palliative care clinician, but then we also knew clearly what her goals were, and they were to travel and to see her great-grandchildren. That's her with her great-grandson. You know you might be listening to a mid-career geriatrician if the conversation quickly turns to, and how are your parents? How is it going in terms of supporting them as they are seeking to navigate aging? And so there are themes related to caregiving and care partner support that we will focus on today. Here are our learning objectives, or our objectives for today's talk, seeking to how we can help patients and care partners living with dementia I'll start by highlighting brain health and dementia risk factor reduction, how we can integrate this into our clinical practice, especially in primary care and across the lifespan. Then I'll spend in the middle third a focus on strategies for early detection, diagnosis, and especially support, highlighting the new CMS GUIDE program. I'm very excited about the collaborative effort for the GUIDE program. This is the first time that Medicare has specifically launched a caregiver-specific reimbursement program. And then I'll also, throughout the talk, link our work at UCHealth to Colorado's state Alzheimer's disease and related dementias plan. So let me start with a case, as we typically do here at Grand Rounds. This is a 73-year-old woman with probable Alzheimer's disease, hypertension, glaucoma, and intention tremor. She's a retired hospital data manager. She loves to travel. Her first symptoms related to cognitive impairment, she had insight about in 2018 with some word-finding difficulties. Like for many, we've seen across multiple studies, COVID truly worsened and revealed cognitive challenges, including difficulties with taxes, which she had done for her whole life, bill paying, and then even getting lost while driving. So she was diagnosed with mild cognitive impairment that subsequently was shown to progress actually quite rapidly to early dementia, and now in 2024 is moderate stage of disease. Medications are fairly straightforward: donepezil, lisinopril, glaucoma drops, multivitamin, and calcium, which she only intermittently takes. Because she's moderate level of dementia, she's not eligible or accepting of the risks for lecanemab, one of the anti-amyloid antibodies. She lives with her husband, who has shifted to being her primary caregiver. So throughout this talk, I'm really also going to emphasize lived experience, because this really motivates a lot of what I do clinically, and is also, I think, important for us as we are navigating what we do in medicine. So this is shared with permission, and actually was written about 3 a.m. after this experience that happened October 21st at 12:45. So we went to bed at 11. My husband woke me up at 12:45. He had heard my mom go downstairs, open a door, and not come back up. Thank goodness she had her phone with her. I couldn't find her in the house and saw on my phone that she, or at least her phone, was half a mile up the road, out of our neighborhood and near a busy street. I drove quickly up to find her, praying for God to protect her. She was standing with her packed suitcase, wearing my shoes, wearing her jacket, carrying an extra coat, and holding her phone. I got out of my car as she was putting her packed suitcase into the car. She said, "I'm so glad you found me. I don't know what I'm doing. I don't know where I'm going." I said, "I'm so glad I found you too. I love you, and we're going back to my house. Is that okay?" As we unpacked her suitcase in my house, including the small space heater from the room that she had packed, I asked if she was okay and if she felt safe. I reminded her that I love her and that I'm glad she's with me. And yet I'm confronted with the reality that we haven't been able to keep her safe. And this is the second terrible near miss in 2 weeks to the day. My mom is confused. She doesn't consistently remember where she lives or how to keep herself safe. For tonight, we have increased vigilance and engaged an extra lock on the door so that we will hopefully wake up if she's trying that door. The next morning, we got up for breakfast. I asked how her night was, and she said it was fine. She didn't remember what had happened. My husband and I didn't sleep that much that night. So as a case, what would you recommend? Dementia care is nuanced, it's challenging. There's so much research happening. It's very, very good, it's very diverse. Clinically, this is one of the frameworks that I use to just try to think in a straightforward way, something that's quite complex. I think about safety, support, social engagement with the person's dignity in the center. And so today we will have opportunity to think about our innovations and interventions that we're implementing here to focus on these different aspects of care. I also want to pause and just recognize for all of you who are clinicians and part of healthcare teams, thank you for caring for family members when we are experiencing these near misses, for caring for those who are experiencing the catastrophe. And for those of you who are caregiving, please reach out to people you trust. Find your team. You can text me. I will text you back. November is National Family Caregivers Month. So I wanted to just share with us from President Biden. He writes, during National Family Caregivers Month, we recognize the love and sacrifice of more than 50 million Americans, providing crucial care to people that they support, ensuring their health and dignity. I won't ask us to do this, but I'm confident that if I ask for show of hands, several of you have had prior experience supporting a person living with a dementia. Some of you are current caregivers. Some of you anticipate and expect that this is part of what you're committed to doing in the future. And some of you, perhaps like me, are in the center of this Venn diagram. So who are dementia care partners? Often family members or friends, chosen family who provides support, resources, and care. They can live locally or at a distance, often multiple people involved in very different ways. Specific to Alzheimer's, 1 in 3 dementia care partners said that their health has gotten worse in the past year. So I hope throughout this talk, you might be taking notes of something that you want to take as an action point. I would emphasize that a key point that any of us and all of us could do in the settings that we're in is identify, name, see, ask about the caregiving experiences that care partners are engaging in, value the important role that care partner is playing. I'm actually not going to take us typically through the epidemiology, the public health aspects of dementia. We know that there are significant problems, that there are gaps in care and research, that it's complex, and that can lead to overwhelm and inaction. I'm motivated instead for lived experiences that inform our research and lead to innovative solutions. So we're really going to focus on envisioning what a dementia learning health system could look like. And this is also sort of an outline for how I'm organizing the innovations that we're involved in. So a learning health system can improve brain health and reduce dementia risk factors, increase early detection and diagnosis, improve quality of dementia care in a number of different ways, increase support for family care partners, and increase connection to community resources and social engagement. So in the first third of the talk, we'll focus especially on detection, diagnosis, and how that can inform support for decision-making, again, with the person's dignity at the center. Just briefly, I have some comments. This is a great new report that was released. The 2024 Lancet Commission has updated their report and identified that there are 14 modifiable risk factors that together account for 45% of dementia risk worldwide. This figure is small, but over the figure, what it's showing is that in early life, that green circle, lower levels of education account for 5% of dementia risk. There are then multiple midlife risk factors, and I think this is an opportunity as we're doing preventative health and through the annual Medicare wellness visit to focus on risk factors such as hearing loss, cardiovascular risk factors, physical inactivity, smoking, and the other risk factors that they've identified. In later life, there are still opportunities also to reduce risk. Chief among this is 7% or 5% social isolation. So there is a growing body of literature, really also trying to test what are the interventions that can effectively engage individuals in meaningful activities to help combat the epidemic related to social isolation, which is a modifiable risk factor for dementia. Risk factors also contribute then to how there are racial disparities in dementia. I think this is a key point for us to be thinking about as we're trying to tailor how we're detecting dementia, how we're counseling related to dementia risk. So as part of Colorado's Alzheimer's disease and related dementia state plan, we have focused on priority populations, noting that the risk of dementia is 2 times as high among individuals from Black or African American backgrounds. It's 1.5 times as high for individuals from Latinx backgrounds. Data from our own campus has shown that the number of individuals by 2016 from an American Indian and Native Alaskan background will be 5 times as high by 2060. So these populations are disproportionately bearing the burden of dementia diagnoses, and then of course also need for community resources and caregiver support. So why does early detection and diagnosis matter? A lot of different reasons, which are listed here. Certainly, it might not be Alzheimer's or dementia, so we really have to be thoughtful when someone is coming to us with subjective cognitive concerns or changes in their functional status to have an accurate diagnosis. This is a shout out actually for tomorrow's geriatric grand rounds. Dr. Bree Betcher will be walking us through the evolving and emerging data related to integration of biomarkers in accurate and timely diagnosis of Alzheimer's disease. So happy to follow up if that's of interest to you. Diagnosis matters also because once a diagnosis is known, I think it's crucial for all aspects of care planning. It can then allow us to have anticipatory guidance, to think about how we can remain independent longer, how we can better achieve the goals that matter to us. It can have important implications, considerations for treatment, participation in research studies, and of course, quality of life. Also, when we know that dementia is present, it allows us to have tailored interventions to work at preventing avoidable emergency department use or hospitalization. So still in this country, there's a vast amount of dementia that is not diagnosed. And yet when we ask people, if you had dementia or a cognitive process that was a neurodegenerative illness, when would you want to know? 55% of individuals said that they would want to know early. They would want to know when it's at the mild cognitive impairment stage. Some of you actually in primary care may already be fielding requests for individuals who are asymptomatic and may be asking you actually about biomarker diagnosis. So more on that will come soon in the next few years. Just as a reminder, clinically, what can a cognitive assessment look like? Who is it for? We could obviously do a full talk on this, but this is just a reminder of who we might be targeting thoughtful cognitive assessments to, how you might do it in terms of asking about cognitive concerns. Certainly input from trusted informants is really key. You can conduct a brief cognitive assessment and schedule for a full evaluation. The comprehensive cognitive assessment and care planning visit is noted here. Billable is 99483. And if any of you clinically would be interested in implementing this into your setting in Seniors Clinic, we are teaching our fellows and we have templates that we're happy to share with you. We actually leverage a lot of the Medicare Annual Wellness Visit questionnaire because there's a substantial amount of helpful overlap. Speaking of the Medicare Annual Wellness Visit, I think this is another key opportunity that Medicare has provided for us to be attentive to cognitive concerns. What is that assessment supposed to look like within the visit? Actually, Medicare gives us a lot of flexibility. I think both in Seniors Clinic and broadly, we have opportunity as UCHealth to define these pathways. What could a meaningful cognitive assessment briefly look like within the annual wellness visit? How could we then link that to agile pathways and potentially link it to then things like the GUIDE model or other support, other treatment options? So just a shout out about the annual Medicare wellness visit as an opportunity that could be further developed from a QI or research perspective. So I'm going to finish this first third of my talk with 2 resources. So for those of you who may be policy-minded or thinking about how you can better enhance your skills related to risk factors, early diagnosis, and care planning. We've developed the CU e-learning module as available CME for you if you want to think about practical opportunities for integrating skills into your clinical practice. We've designed this especially for Colorado primary care clinicians and highlighting our priority populations. Here's also a QR code related to the state plan. We're very fortunate that Colorado is a leader in implementing this public health approach. There is a wonderful state website as well as a 211 website trying to really concentrate and make it easier to find community resources related to dementia. So feel free to reach out if you have more questions about the state plan activities. So I want to now really shift to what can we be doing once someone has a diagnosis and we want to focus on safety, support, and social engagement. There's been a lot of research in this area over the past 2 decades. What I'm showing here is a synthesis from 2018 from the gerontologist that summarizes what person-centered care can look like related to dementia. You can see that there are multiple components. There have been 6 different evidence-based models that have been tested nationally, and those then have informed what can longitudinal case-based navigation look like for individuals. And we're very excited that with all of that evidence, then President Biden had an executive order in 2023 where there's this aspect of it calling for an innovative new healthcare payment and service delivery model focused on dementia care that would include family caregiver supports such as respite care. So with this guidance, CMS then developed the GUIDE model. This is testing an alternative payment methodology for participants, so in this case, us as CU Medicine, that can deliver comprehensive, coordinated dementia care. This advances key goals of the National Alzheimer's Disease Plan. So on July 1st, 2024, Medicare released the fact that they had selected 390 participants. There are 6 programs here in Colorado. It is very exciting that we are able to be one of the programs. CU Medicine, in partnership with UCHealth, as well as the Holding Group and Sangre de Cristo, are currently existing programs actively enrolling Medicare beneficiaries. The other 3 listed here, Bloom, True Community Care, and Hope West, are in the preparation year, and they will start enrolling in July. So across Colorado, it's exciting that we have 6 different programs to offer this dementia care service and program to individuals. People can be in one program at a time. So an overview of the GUIDE model. The focus is to improve quality of life for people living with dementia, to enable them to remain living in their home and communities, and importantly, to provide caregiver training, education support, and reduce the strain on unpaid caregivers. It's an 8-year demonstration project. Beneficiaries must be fee-for-service. That means they can't be Medicare Advantage, receiving hospice, or part of a PACE program. InnovAge here locally in our area. Patients must have a dementia diagnosis of any type confirmed through a comprehensive assessment. We here have a lot of value-based payment programs. GUIDE is designed such that our patients can be in more than one value-based payment program. So that's really quite permissive and inclusive in a good way. Beneficiaries can stop whenever they desire to. So what is the program? Here we've listed the key program components. There is a lot of synthesis across what worked in the 6 evidence-based programs that were tested. So these are the care delivery requirements. They really closely reflect what's important in terms of personalized, tailored, longitudinal, dementia-specific support. We here have several dementia care navigators who are trained and delivering this. They're based out of UCHealth Seniors Clinic, but we're able to support and serve individuals across UCHealth. I think what's also notable is the respite opportunity. And even just today, we found that our contracts with partner organizations have been approved. So it's been a bit of work setting this up, but we are excited. So just to tell you a little bit more about the Guide Dementia team and then how you can find us. We are interested in helping to support dementia care across the system. So while the Dementia Guide program will have specifically enrolled individuals, we also are a resource to all of us. So you can reach us at this EPIC pool listed here, as well as sending referrals to us. I'll show this information again on a future slide. We are not just serving seniors clinic patients, happy to receive referrals for anyone who has traditional Medicare, who has dementia, and who has been seen at UCHealth and desires their care to be coordinated through us. So that could be inpatient, through neurology, through primary care clinics. This is an example of the sheet that we send directly to patients and care partners when we're outreaching to them to share with them about the GUIDE program. You can tell it's a complex program, so we're trying to make it as understandable as possible in terms of what the enrollment looks like and then what the program participation copay aspects are. There are no copays with this, which is a huge advantage for patients. It's integrated and covered by their Medicare, and they continue with their current care through primary care, through neurology care, and we come alongside with dementia navigation. Just as a sort of internal comment, for those of you who are inpatient or wondering, is this patient in the GUIDE program, you'll be able to see in the storyboard that there's a patient flag noting GUIDE program. You may also see our notes as patient outreach encounters from dementia care navigators. So how have we been doing so far? Who's been supported through dementia support programs here at UCHealth? I'm really grateful that we've been able to be early adopters. So even as early as 2018, we started a program initially funded through Comprehensive Primary Care First and based out of Seniors Clinic. Some of you may remember that as the Living with Dementia program. So we had 175 Seniors Clinic patients and care partners served. And because dementia is an illness that has a trajectory, we actually continue to serve some of those patients who we first met in 2018 or 2019, and they've continued with the same dementia care navigator. In 2023, last year, we expanded our program as part of an NIA R01, a multi-site study to specifically implement the care ecosystem version of the evidence-based dementia support program, and that enrolled 153 additional patients and care partners. Enrollment finished in June, and all of those individuals receive 1 year of the dementia care support. We will then be involved in the cost effectiveness, patient-centered outcomes, caregiver outcomes, healthcare utilization analyses that are involved in looking at that pragmatic study across 6 different sites. We really appreciate the participation of multiple primary care clinics and neurology in this. And then this July, we started enrolling for the CMS GUIDE model. To date, we have 22 individuals and their care partners who are enrolled. We're actively scheduling alignment visits, and we are working through referrals that we've received. We've already received more than 60 referrals. We welcome additional referrals for us to really get this program started, because we know that when someone is facing a new diagnosis of dementia or a near miss or a catastrophe, that we want to be responsive to coming alongside. We're also looking in 2025 additional opportunities to support dementia navigation, especially for Medicare Advantage individuals. So I've told you about the program. Now I want to give you a flavor of what it's like to actually be part of dementia care navigation. So here are the sort of a description of a case that one of our navigators shared with me. So this is a patient with moderate stage dementia who lived alone in independent living, and her daughter moved from California to Colorado to assist with supporting her. When the program first started and the care navigator was reaching out and talking with the daughter as the primary care partner, the daughter was often tearful on initial calls, felt as if she couldn't do anything right, just tremendous guilt, and had many questions if her mother still loved her. So the intervention is monthly outreach calls where the dementia navigator is talking directly with the care partner. And through that process, the care navigator actively listens to what are the gaps, what are the needs, how can care be tailored. And so the care navigator provided a lot of dementia education, caregiver support, connection to multiple community resources. I think that our care navigators are some of the most up-to-date, knowledgeable individuals in our system in terms of what's currently available, support groups or who's enrolling, a wiser mind, other resources. And so the care navigator is also a friend on the inside, as I'll describe in a little bit. But the care navigator is able to share information with the primary care clinician ahead of visits so that the daughter who is afraid about things being brought up in the context of a clinical visit could still know that information was being conveyed to the PCP to ultimately coordinate comprehensive care. So overall, this resulted in the care partner growing more confident and knowledgeable in her role as a carer. They also saw that their relationship improved, where the dyad began communicating and trusting each other to more extent. The patient became more receptive to assistance from her daughter. And then eventually the patient was also receptive to thinking about moving to a place and a location for more support. So this longitudinal tailored opportunity for dementia education is hugely helpful. I just wanted to summarize a bit of additional feedback. You can think of it as qualitative data in the context of a QI study, but we're grateful, and especially when the dementia is so challenging and overwhelming, our navigators reflect on the feedback they've gotten from care partners, knowing that they are making a difference, they are helpful. You can see so many just great feedback. Without this program, I would be a disaster. I depend on it as an example. We've done a couple different studies and have published the different types of referrals and different outcomes that we've had related to caregiver burden, emergency room visits, and hospitalization. In a very, also just very recently, what are some of the tangible outcomes that we've been able to see? You can see here that through involvement in the program, the care navigators have supported the care partners in being able to set up systems and supports and processes and new routines to navigate many of the challenging aspects of dementia, whether that's wandering, difficulty with activities of daily living, difficulties with driving. We do a lot of support related to caregiver mental health, and in one case, noted stopping caregiver suicidal ideation. That is a huge win. Helping individuals have more of a restoration of their relationship between the care partner and the care recipient, avoiding going to the ED through use of dispatch health, and just also acknowledgement of what's delirium, what might be a bladder infection, what's the appropriate means of support, rather than automatically being told you need to go to the ER. Just wanted to just sort of that aspect of a friend on the inside. So if you're in clinic trying to see if someone's open to dementia caregiver support, you could certainly reflect on this. It's an opportunity. We know this is complicated to have a friend on the inside. A caregiver wrote, "The reality is that my conversations with you were like a therapy session for me. It could almost be considered respite time. The resources were necessary, greatly appreciated, but the phone calls were like a breath of fresh air. I felt like I not only had a counselor, but a friend as well who I could speak with, and having that was very important to me as a caregiver." So again, we're here. This is how you can find us in the EPIC pool. And if you have individuals that you want to refer to us, we have embedded in this guide dementia referral, which should be available across all of our teams, not just physicians, that there's also the eligibility criteria embedded into this referral. It's not an order, so this is still a staff message. So I think this is also really something that our dementia navigators take pride in. One of our navigators described her role as this: I get to be a guide and a support for families navigating one of the most challenging times in their lives. It's incredibly rewarding to know that by connecting them with the right resources, offering a listening ear, and helping them navigate complex systems. I'm making their journey a little easier, giving them hope and ensuring they don't have to face this alone. So I appreciate that we have opportunity to set up this program, that it is person-centered and rewarding for all of us involved. I'm now going to shift to the final third of sharing about innovations that we've been working on. Again, thinking about this continuum or this spectrum of needs and opportunities related to dementia, from early detection and diagnosis all the way through to support and safety. So many thanks. We've just finished a multiple site clinical trial that was led through the Palliative Care Research Cooperative. The trial was called Alzheimer's Disease and Related Dementia Palliative Care. For those of you who have worked inpatient as a hospitalist or been on the palliative care team, thank you for helping us to successfully serve individuals with advanced dementia when they were admitted, randomized to either a specialty palliative care with dementia adaptations versus usual care. Together, we enrolled 103 dyads, helping to successfully complete total enrollment of 423 dyads. This is a tremendous advance in terms of what we can know about palliative care for advanced dementia and helping with what's needed from inpatient all the way through to the transitional care period. So our thanks to you, and results from that study will be coming forth in the next year or so. I also, on the right-hand side of this, want to highlight some of the learning health system innovations that you may have had experience with or might be in action for you to look into. So for those of us in primary care familiar with Agile Pathways, led by Dr. Laura Mackey, pulling together an interprofessional team of us, we've set up cognitive assessment and evaluation pathways that are existing in EPIC, and we will continue to update those as there's more information about biomarkers or the disease targeting therapies or the GUIDE program. So please take a look at those. I'll share a bit more about decision-making capacity because it is ready to launch soon. A number of us are working on care partner identification. So this is tricky. I think each of us clinically at the bedside or in clinic can identify who's the care partner. It still nationally becomes very challenging of, well, where do we document that? How can we know what their role and involvement is? And so that's an emerging and evolving area of research that we're doing some here with related to patient portals. I'll share with you a little bit about dementia care quality as some of the pragmatic outcomes that we're embedding. And then Livy Chatbot is sort of an innovative use of technology that we're starting to explore as a means of evidence-based information directly to UCHealth Public. So for those of you who work inpatient and or might be involved in capacity assessments, this is work led by Erin Nielsen and Emily McDonald. Please reach out to them if you would like more information and training and teaching specific to your unit. But as a reminder, we can use .decision as a smart phrase that prompts us in how best to evaluate decision-making context, decision-making capacity in context and in an interprofessional team. There's also going to be a new Agile pathway that's launched on December 3rd. So just in a timely way, I wanted to increase awareness for all of us that in dementia, as one example of a condition that almost always has capacity-related issues, where there's a need for supported decision-making, please consider using the .decision smart phrase. Related to a lot of the work that we're doing, a resource that we want to provide to you and that you are welcome to email us for is a dementia enhanced resource guide, especially in the Denver metro area, but also includes national resources. We have this 30-page guide, best distributed electronically, that we recently updated and will update approximately every 6 months or so. We've also created this in English and Spanish, led by Thais Protasio and Ellie Cranky, really calling all of our local organizations and finding which organizations feel comfortable and are able to meet the needs of Spanish-speaking individuals if that's their preference. This guide has both English and Spanish available within one guide. Just one snapshot of Livy Chatbot. A number of us are thinking about how could we develop pragmatic technology that could link people to evidence-based resources. If you were to pull up Livy on your UCHealth, you could type in memory or dementia, and you would get to a pathway that we've built that we hope to enhance over time and lead individuals with dementia, or especially care partners, to this pathway so that they may be able to find community-based resources or other guidance that would be helpful. We know that care partners may be looking for information at any time of day, but say 11 p.m. or 3 a.m. And so this is there asynchronously. I wanted to give just 2 slides about a current research study that we're doing related to trying to develop pragmatic outcomes that we can measure to help improve the quality of the types of innovations that we're doing. So if you happen to be supporting someone living with dementia or know someone who is, we would welcome their participation in this brief survey study where we're focusing on optimizing this and a second survey. So as a screenshot here, this is the caregiver's perspective of dementia care quality. It already exists we've had it built within UCHealth. It's going to be able to be sent through My Health Connection. And that really gives us a chance over time, say annually, as sort of part of a learning health system approach to receive feedback from care partners of how would they judge the quality and satisfaction with dementia care. This is my near final summary slide. So I just wanted to zoom back out and appreciate the work that we're doing and give suggestions related to how we can partner, support, engage care partners and persons living with dementia in different types of resources. You have a wonderful team that you're part of. Use your team to tailor the care. There are a number of different referrals that can be supportive. There are community resources and then online resources available nationally. So we also, as another plug, are happy to send out the resource guide that summarizes many of these items. So I hope as you've been sort of thinking about the different aspects of innovation that you might pick one, consider an action that you might take. Could be to identify a care partner or build that into your routine, ask about their needs. Could be to engage diverse patients and care partners in hearing their stories and elevating their lived experience. Could be to be thinking about in your clinic, could you develop a QI workflow around cognition in the annual wellness visit? We'd certainly be happy to converse with you related to guide referrals or future opportunities that we'll have. Learn about a community resource specific to dementia or social engagement for older adults. We're very happy to partner and support any desires you have related to education, training, or research related to dementia or caregiving. And for those of you who know someone supporting someone living with dementia, send a text to offer support. That is helpful. And for those of you who may be caregiving, make a phone call, ask for help. And so with that, we'll switch to questions. Thanks so much for your attention.
Dr. Holm, thank you so much for that talk. I'm sure there's going to be some questions from the audience. I already see one in the back with Larry, and as MFA gets there, I'll take the chance to ask the first one. CMS is making this available for 300 plus clinical sites across the US. What's the plan from a CMS perspective in terms of evaluating this program to know that it's successful? How are they going to do that? And what data points are they going to use to know that they're successful?
Yeah, great question. CMS will, like for all of their demonstration projects, have contractors specifically involved in that. The information that we are reporting to them, which I know will be part of the evaluation, includes caregiver burden. They are also going to look at healthcare utilization. They're also looking at appropriate medication prescriptions. So we are submitting some of the quality metrics that already exist, but specifically for our enrolled participants in GUIDE, we'll be looking at potentially inappropriate medications for these individuals. And then I think from a research perspective, there's lots of opportunity for us to do additional evaluation.
Larry in the back.
Great. Thanks, Hillary, for all your work in this space. You know, it's impressive on a good way about how much you've developed, how many practical tools you've created, how you've really helped give us here things that we can use. It's also impressive in a bad way how dizzying it is, right? Like one of the problems with medicine is it just keeps getting more and more complicated. It's not just more complicated for us, but as you mentioned in the talk, it's more complicated for patients. It actually struck me that you know, you have all these different places you can find these tools, but it's actually, I had trouble sitting here thinking about how I would remember and go and find all of this. Even your dot phrase, we're required to make dot phrases that start out with AMC, then GUIDE. But if I really wanted to find something about dementia, I would probably type in dementia first. So we don't even label things in a way that can make them be found. So I guess a question in that, you know, is what are your thoughts around how to make this more accessible? Because all of us probably need to help out with some dementia care. It's not going to be that we send them all to you. And then specifically, what successes have you had in terms of implementation around simplicity?
Yeah, I appreciate that question. It is extremely complicated. And so even as I try to work in like, what are the smaller buckets to lump rather than split, I know that there's many, many, many details within that. I do think that thinking about in the main context that any one of us work on and focusing on knowing the tools that work for you in your context, that there's so much, and yes, this was an overview. I encourage you to just pick one thing that you want to learn more about, perhaps, and to see us as we can then help direct you to what one thing. I remember that Dr. Lum said something about this. What was that? So we are happy to be the point of contact. I don't think that any of us will know all of it, nor do I think that I know everything that's happening related to dementia care. And it is just the reality that things will continue to evolve. You're right, even though we named it .guide dementia referral, already we're realizing there are new codes that are going to hopefully allow us to do dementia navigation, and we're still going to want to use that same pathway. So it is a tension, but I try to not let perfect be the enemy of the good.
Other questions? Shanta.
Thanks so much, Hillary. Stepping up and maybe into an even bigger spot, if you were to recommend to us advocacy things to focus on, what would you say as a physician community or a healthcare provider community we should be advocating for next in terms of support for patients and caregivers?
Well, the most immediate advocacy is, I think, telehealth is important. So hopefully there will be a decision to extend the telehealth benefits from dementia and caregiving support, where so much care is at home and it's difficult to navigate our health system. The more we can do at home, telehealth is a key benefit to that. I think that it is, there is a lot related to caregiving legislation that is already in place, and actually there are opportunities for build systems to even fulfill some of the caregiving policies that have passed. And I am excited about the opportunities that Colorado has already built, both in recognizing caregivers and then also in us moving forward with community health workers. I think it's an opportunity within this for us as a system to sort of leverage some of the policies that are already in place.
Thank you so much for your wonderful talk. One of the questions from the chat is considering the prevalence of dementia and that we want to catch it early, is there any evidence for just screening with a MOCA at annual wellness visits, if not biomarkers, as opposed to an annual wellness visit questionnaire, which I assume are less validated for MCI and dementia?
Yeah, great. So big topic there, big question. I do not recommend biomarkers as screening. And I don't think that it's needed or practical, or that there's clear evidence that a cognitive assessment that may take 5 to 8 minutes, like the Montreal Cognitive Assessment, should be implemented. I have been moving more toward asking a question of subjective cognitive decline, which is validated by the CDC and has been released in national surveys. So if you're going to ask one question in the annual Medicare wellness visit, you could ask, in the past 12 months, have you noticed change in your memory or thinking? And then go from there. Because if someone says no, then you really don't need to go much further. I think it's also true that in the annual Medicare wellness visit, it is likely not practical to do a 5 or 8 minute cognitive screening test. You could potentially do the mini cog.
Hi, excuse me, that's very loud. So thank you so much. That was fantastic. And I think you highlight so many important things that we need to be thinking about people with dementia and their caregivers. I guess a practical question I have is, in, say, the Denver metro area, you mentioned that for a lot of these programs, they have to be a CU medicine, patient to know about these opportunities. But I mean, I think that they would benefit lots of people who maybe don't get their neurologic care or their geriatric care or primary care within our system. Is there a way that people can get connected with you and be able to participate in these studies, or be able to get some of these services, even if they're not within the system primarily, and without adding extra stress of them, necessarily coming, to the Anschutz campus? Are there other locations that you guys offer these things? Because that is a burden for people who have difficulty traveling and stuff too.
Yeah, certainly. And so I think it's going to be different for every innovation that I'm speaking of. But specific to the GUIDE program, Medicare has really sought to incorporate health equity and access into how they develop the GUIDE program, such that we are really being asked to have the program be as available and enrolling individuals who may face more health equity challenges. One of the ways that they're doing that is that Medicare will send letters to individuals who have a dementia diagnosis to let them know which GUIDE programs exist. Now, that we will see how that goes, but that's an outreach that Medicare will do so that people can have awareness that Medicare is launching a comprehensive dementia support program. Certainly, we hope to get the word out in thoughtful ways. Individuals can then choose care at UCHealth. They don't have to already be established within UCHealth. The GUIDE program in particular is all telephone or telehealth based, so it wouldn't actually require transportation here in particular. So just a handful of ways, but you're absolutely right. We have opportunities for dissemination, increased awareness, implementation in community settings.
Thanks, Hillary. I think there's a lot of information here, and I heard Larry say, I'm feeling a little bit overwhelmed. If there was like 2 or 3 things that you'd want someone to take away or to look into or to know to refer, is there a couple of things you'd highlight?
Yeah, I think that asking about care partners, like recognizing who they are in the clinical visit, is something that all of us have opportunity to do in whatever setting that we're doing. And so that doesn't feel like an evidence-based intervention. And yet so many care partners feel invisible, feel that they're not heard or understood. And so I do think that that's one clinical referral and action that we can incorporate into our clinical practice. The second would be that we are available to answer questions related to dementia-specific resources because I recognize that we're in so many different settings. A specialist seeing someone in eye clinic, that social worker may have questions about dementia, may recognize that overwhelm is happening, and they don't need to know all of the resources, but if they know to reach out to us, we are then happy to help them.
I think with that, we'll conclude. Thank you so much, Dr. Lum, for the presentation.